The next presentation is by a maternal fetal expert, Dr. Deepak Parmar. Dr. Deepak Parmar is an MFM currently working at KUTRH, Kenyatta University Teaching and Referral Hospital. He is one of the upcoming many maternal fetal, and he will be presenting a very interesting case, which is in line with some of the discussions we've had in the morning as a follow-up to Dr. Ikol's presentation.
Good morning, everyone. My name is Dr. Deepak, and I'll be presenting you on a case that we handled of fetal tachycardia. I always say for this particular case, it was fetal tachycardia, but equivalent to an obstetrician's tachycardia. We managed this as a team. I'll mention the team players. So basically, this was a patient who's gravida 6. She is para 2 plus 3, 38-year-old, who had gone actually for her routine clinic visit, and at 25 weeks of gestation, where just on routine auscultation, they noted a fetal heart rate of 250 beats per minute. Of course, the obstetrician was quite alarmed, and it was Saturday, I remember. So I was called and I said, okay, the beauty is it's 250 beats per minute. It's unlikely that will be an obstetric issue. So we will review her the following week. In terms of our first trimester screening, basically her routine screening was normal. The first trimester nuclear screening, she actually had a high risk for T21, although she opted not to follow it up. She was referred to the MFM unit for further follow-up, although she did not pursue to follow it up. So this was the doctor on that particular time, didn't really know what to do with the patient. And definitely this was the baby who was giving the obstetrician quite some stress. This is our obstetric history. In 2015, she had a preterm delivery, live male infant, 2 kilos. In 2020, she had a termination of pregnancy. We didn't have access to her medical records, although she reported it was due to some renal anomalies. In 2021, she had a preterm rupture of membranes, premature rupture of membrane. She delivered a live male infant, 2.5 kilos. Of note was she mentioned that in that particular pregnancy, she had polyhydramnios. We inquired if she had been screened for gestational diabetes, of which she said she was screened, but it was normal, so she didn't have any GTM. And the subsequent pregnancies in 2023 and 2024 were first trimester miscarriages. So after referral, she came to us, visited us at Kenyatta University Teaching, Referral and Research Hospital. And we did both an anatomy scan at that period, as well as evaluation of the fetal cardiac rhythm. So we had, in terms of the fetal cardiac, anatomic cardiac evaluation, we didn't really see anything abnormal. But one thing was she did have fetal tachycardia. You can see the heart rates were 246. So we did both the atrial and the ventricular heart rates, which are close to the same. So the reason for doing both, so if you look at the M mode caliper, it's moving from the left ventricle to the interventricular septum to the right atrium. We want to see the conduction because the conduction does come from the right atrium, the synatrial node comes to the AV. So we want to see the synchrony between the contraction of the atrium and the ventricle, the two chambers. And you can see every contraction of the atrium is followed by the contraction of the ventricle. So in terms of the rhythm, yes, there was tachycardia, but there was also preserved what we call 1-to-1 ratio between the atrium and the ventricles. She had a mild pericardial effusion of around 3.5 millimeters. And in terms of the other findings, we did have ascites noted at 25 weeks, and the estimated weight at that point was 1.2 kilos. The 25-week gestation was based on her death, although our biometry was giving us close to around 28 weeks. So this is the same picture showing the people tachycardia. So we gave our students because we looked at the element of fetal tachycardia with the fact that with high drops, we may possibly have a preterm delivery. We did a maternal ECG, which was normal. We did other baseline tests, the UCs, the HbA1c, the thyroid function tests, which were normal. Uh, there were no features of sepsis. We had done a TBC, which was normal. We did screen Anna for GDM based on the fact that we had polyhydramnios in the previous pregnancy, and we actually discovered that she actually has GDM and we initiated our metformin. We now had a multidisciplinary team discussion. So that involved the pediatricians, the pediatric cardiologist, the neonatologist, and in this particular scenario, we also involved the adult cardiologist. So the pediatric cardiologist as well as the neonatologist were quite comfortable in terms of we will come towards the potential diagnosis, and they thought that we can cardiovert the baby, um, similarly to what we will do for adults, and see what the response will be. One of the major considerations was the fact that the mother, mentioned a gravid mother, 25 weeks gestation, we were concerned about any potential side effect to the mother because what we were considering is using flecainide, um, which the goal was for it to cross transplacentally and now help us with cardioverting the fetus tachycardia. So the dosage that we recommended was flecainide, a loading dose of 100 milligrams thrice a day for a day, and then to continue with 50 milligrams twice a week with close monitoring of the mother. For us, we decided to monitor the mother as an inpatient. Um, in terms of the choice of the antiarrhythmics, we had two choices, were the digoxin and flecainide. We noted that the maternal side effects of digoxin, the nausea, fatigue, vomiting, and the sinus bradycardia. So after discussing the potential side effects besides flecainide has, and even from the input of the cardiologist, we said generally flecainide will be better tolerated by the mother. So we opted to go for that. And the plan was to use one antiarrhythmic. If there is poor response or lack of response, then we would consider the digoxin or cetalolol to the management. Interestingly, the patient was not patient. So one of the things even before we started therapy was the couple wanted a termination of pregnancy based on the findings that we had given to them. Um, we had the MDT and the MDT actually kind of declined the offer to the request to do a termination of pregnancy. And hence, after 4 days on flecainide, the mother was not quite convinced that she was getting management as per what she desired. So she opted to actually get discharged and opt for a second opinion. We advised her to continue flecainide. To be honest, we are not very sure how long she may have used for. She mentioned that she used it for 3 days after discharge and discontinued. But that will be difficult for us to know. So 10 days later, she met me again at a second opinion. Um, I noted that the ascites were actually worsening compared to the previous ascites that were there. So you can clearly see that around the margin of the liver there is quite fluid accumulation. You can see the bile floating. The pericardial effusion was still there at around 3.3 millimeters. But one interesting thing was the cardiac fetal heart rate. We managed to actually have a normal fetal heart rate. We had a ventricular heart rate of 126 and the arterial heart rate of 132. So at that point, the other thing was in keeping with the high drops. On the right side, you can see that we have a dilated or the more prominent inferior vena cava, which will actually be in keeping with the features of high drops. So now the plan was, what do we do? Because we now have a regular fetal, I mean not regular, but we have a fetal heart rate that's within normal range, but with a fetus with increasing hydro severity in comparison to the previous evaluation. We again rediscussed the case and our plan was to continue conservative treatment. And this time the couple, I think, was in agreement with us. So that's the M mode evaluation of the fetal heart rate. You can see when we try to evaluate other causes, of course, of fetal tachycardia, like any features of anemia, that was at 2B. There was no other anomalies that we could see. So 2 weeks after that, so this was on 21st of December. So I saw her again a month later when she was actually around 33 weeks. At this particular visit, the high dropped. We saw a resolution of the ascites. The fetal heart rate was still quite within the normal range of 132 beats per minute. And the fetal growth was also within normal range. Fetal weight was around 2.1. So we made a decision that we would aim for term delivery at 8 weeks because she had gestational diabetes, which actually got well controlled with the metformin 500 milligrams once a day, and will be an induction of labor at term. So we did an induction of labor at 38 weeks. We had a live male infant, 3.2 kilos with a good F+4. She was assessed by the pediatric and the neonatology team, and there was no concern that was raised. I met the mother after 6 to 8 weeks. She brought the baby for vaccination. Baby was doing fine, healthy, and that was the picture of the mom and the baby. So it was for this particular case, it was quite some involvement in terms of a team. So for the obstetrician, actually me, Dr. Kigondu, and Dr. Pamela Muga, who was actually, Dr. Pamela Muga is actually the first obstetrician who encountered this mother at the 25 weeks of gestation. Then we had discussions also with Dr. Kigondu, as well as now the team at KUTRH. Um, so that was just a overall presentation in terms of the fetus. I'll not dwell because cardiac conduction can be quite a depth in terms of for us obstetrician, but generally this is the normal cardiac conduction, electrical activity that we have. So we have the sinoatrial node that comes to the AV nodes, and then there's the conduction by the left bundle and the right bundle by the bundle of His, and that's typically the electrical activity. So for the normal rhythm, we talk about a regular heart rate uh, with a heart rate of 100 to 180. As we know, normally we talk about a normal rhythm, normal heart rate of 120 to 160. In terms of a cardiac conduction disorder, the range has been kind of made more broader. The reason is we want to also, there've been elements where fetal heart rates of above 160 that have ended up coming to the MFM units across the world, and yet they turn out to be benign. So to reduce the risk, the referrals of preferably low risk mothers or babies, sorry, if you have a heart rate above 180, then you can refer the pregnant lady to our MFM unit, as well as a bradycardia less than 100. Um, um, so in terms of arrhythmias, they account for 2%. We normally have irregular rhythms, either, and in this particular case, we had tachyarrhythmias of above 180 beats per minute. So in terms of the irregular rhythm, commonly we have, sorry, just give me a minute. Sorry for the interruption. So in terms of the irregular rhythm, the most common cardiac conduction disorders that we actually see are premature atrial contractions. Um, that's the most common. Actually, what we are presenting in terms of sustained tachycardia, it can be a sinus tachycardia, which may be related to maternal conditions. What we thought in this particular case was a supraventricular tachycardia, where you have heart rates between 200, 250 up to 280. Atrial flutters tend to be quite, the heart rate tends to be almost above 300, all the way to 500 beats per minute. Um, then you do have cases of bradycardias, which generally may be related to heart blocks. Um, so this is just a small overview in terms of the premature contractions or the premature atrial contractions that we have. So they're the most common. So we need to evaluate what's the origin. So you need to establish what's the actual contraction of the ventricular contraction and where possibly you may have the ectopics coming in. And you also want to see for premature atrial contractions, you may have an atrial heart rate of maybe 200, whereas the ventricular heart rate is at around 140. So if it's conducted, you may find almost the heart rate synchronizing in terms of 200 to maybe 180 beats for the ventricles. But if it's blocked, you may find the atriums contracting at almost 180 times per minute, but the ventricles are conducting normally at 140. And you also have to check whether it's random or it's actually of a rhythmic pattern. So you'll use both the M mode, which is the motion mode, and also the Doppler mode to evaluate that. And also the progression. Progression means now at a particular gestation, how it progresses and how it affects the pregnancy and the fetus, as basically in terms of the evolution to any features of hydrops, um, features of any hydrops, so that we can decide on the possible intervention. Sinus tachycardia is, I think, what we will commonly encounter. So in mothers who are anemic, fetus who are anemic, mothers who are having fevers or fetal thyrotoxicosis, mothers who are on certain drugs, as well as fetal distress. There's atrial flutter. Generally, in atrial flutter, you just tend to have a heart that I think it's not showing well. Sorry, the atrial flutter video is not showing well. Um, so this is how we would actually classify um, sorry, I got disconnected. So this is how we'll typically manage a patient with um, ventricular tachycardia or atrial fibrillation. So supraventricular tachycardia, um, the outcome. So generally, the prognosis or the outcome depends on whether the fetus is hydropic or non-hydropic. So in this fetus, by the time we met the gravid lady, we did have features of hydrops. So that was our concern, because we were concerned whether we will have we'll end up having a good prognosis or not. So the couple was informed that the fact that we have hydrops, um, the atrium is actually not getting enough time to actually relax. So that's why the heart failure develops, but also that does affect the prognosis. Two, the transplacental, um, and that's why one of the other reasons why we chose flecainide over digoxin. So there's the giving the digoxin or the flecainide to the mother, and and allow it to cross to the fetus. So we do want to give it at a very low dose because to reduce or to avoid any risk of maternal side effects, but at the same time also wanting to establish a cardioversion to the fetus. So because even in when you do have hydrops, the amount of drug that is actually crosses to the placenta is also reduced. So you may have to increase the dosage of the medications. Um, the second line means you would add a second antiarrhythmic. So in this patient, we were considering adding digoxin because after 4 days there was no change. So although at that point of time the mother was not in agreement with adding digoxin, and at that point is when she decided she would wish to seek a second opinion. And in terms of delivery, in this particular case where we actually had successful cardioversion and we had no the hydrops resolved, we opted to go to term. In cases where you do not have successful cardioversion or you have features of hydrops, you can even consider delivery as early as 34 weeks. So it depends on the gestation to which you make a diagnosis and also on subsequent follow-up. So this is basically my presentation. Um, I would really thank the team that was involved in managing this patient because it was quite a joint effort and we did have a good outcome for this particular pregnancy. Um, so I'll be open to any questions if there are any. Thank you very much.
Thank you. We have 5 minutes for questions.
Thank you, Dr. Deepak, for that presentation. Just mine is a question on the initial monitoring on the patient. This patient, I think from the presentation, was shown to have high risk for, I think it was trisomy 21.
Yes, you're right, Doc. Sorry, not getting you now.
So as part of routine follow-up for this patient who has a high risk for the 21 trisomy, was there a
Doc, I lost you. You mentioned that high risk of trisomy 21. Is there I lost you at that, sorry.
Yeah, the mic is being changed. Is there?
Okay.
So was there a plan for a routine, not really routine, but was there a plan as part of the, the anatomy scan? Maybe the patient who was missed at that point, was there a plan to do an early, fetal echo, just as to complete that workup for that patient who has a high risk for the trisomy? Thank you.
Actually, that's a good question. So now, there's a couple who was very interesting. So she started her clinic run in one of the private hospitals. When she was informed about the high risk of trisomy 21 and the need for further investigations, she changed her hospital because she did not want to do any further investigation. Even the aspect of when I did the scan at 25 weeks, I was not even aware that she actually had a first trimester screening done, which noted that she had a high risk for T21. It is towards actually at the 33 weeks when coincidentally she brought all her medical records. And then as I was going through one of the medical records, I noted that that was documented. When I brought it up, she said she was really not concerned about it. So that was the challenge. You are right. You would actually want to do a fetal echo. Nowadays, actually, even by first trimester, at that point of time, 11 to 13 weeks, we can actually do an early fetal anatomical evaluation. You will not want to wait till the typical 24, 25 weeks, but you will want at 20 weeks to a detailed cardiac evaluation. She did have a fetal, not a fetal anatomy surveillance scan done at 20 weeks at another facility, but that was reported as normal.
Excellent. I think that is very satisfactory. Thank you very much, Dr. Deepak. And I think this shows. Sorry? No, there was no face. Mlionekana. Deepak, kata jina.
Yes.
Kata jina kwa picha next time. All right.
Oh, sorry.
No problem. We try to hide.
Thanks for that.
Thank you very much, Deepak. We are very much appreciated. Now, maybe you can start seeing the roles of maternal-fetal medicine and a multidisciplinary team. And the more we do these presentations, the more you know what to do when this arises. When I saw this patient, I put in my clinic, the fetal heart rate was 254 beats per minute. So I had never seen that in my whole life. So that's why I consulted the fetal maternal. Before even that, as you have seen, we are managing tachyarrhythmias in fetuses. Sasa, these pre-interns, first you must know how to manage the ones of adults first. So when you are going to school, before you even start here, you must know which medications to use for tachycardias when they come to our patient, when you start your internship in 3 months. So mufanye ACLS, madam, tafadhali.